Good evening, everyone. So another session of Gurukul is yet to start. So it's an interesting case presentation on respiratory system. As always, we are up to every system, and this month is the turn of respiratory system. So first of all, I'd like to welcome our President Jhankhana ma'am, and request her to give some kind words on the occasion.
Thank you, Dr. Lata. Good evening, everyone. I welcome Dr. Baldev Prajapati sir, Dr. Sonia, Dr. Shah, and Dr. Bankar sir. For today's respiratory disease case, respiratory disease is nowadays OPDs are full of with the respiratory disease, and learning in the respiratory part is a opportunity. And today's our horse is Dr. Darshan Pandya. And with respected Dr. Baldev Prajapati sir, we learn a lot from today's topic, respiratory disease cases. So I welcome everyone and over to Lata to start the meeting.
Thank you, ma'am. I'd like to welcome Baldev Prajapati sir. He's the person who is always behind these academic activities. So welcome, sir. I'd like to welcome Dr. Sonia Bhatt, ma'am. She is faculty, professor and head of department at FH Medical College, Agra. She has been national faculty to so many respiratory courses and modules, and she has been national co-convener of advanced asthma course. She has n numbers of papers in her kitty. Welcome, ma'am. She's expert for today.
Thank you.
So, without wasting much of our time, we'll like to start the case presentation with due permission from Chandram and Baldev sir. So, should we start it?
Yes.
Okay. So, today's presenter is Dr. Darshan Pandya. He's second-year resident at Dr. Yogesh Medical College and Research Center. And the guide or mentor is Dr. Chirag Bankar. He's assistant professor at the same institute. So, Darshan, you can start your presentation.
Yeah.
Thank you. Good evening, sir. Good evening, ma'am. Myself, Darshan Pandya. I am going to present a case on respiratory system.
I think, Dr. Darshan, for your just information,
yes, sir,
that you may share your PPT with the history part. Whenever we feel that it requires some discussion, I will request you to stop sharing. And I hope that some other students from our institution and other places are there so that we can make it more of the interactive.
Yes,
And of course, whenever we are stuck up or something, Dr. Sonia is there to help us.
No, sir, you are there. So the expert, you are always there. We are just, yes, sir, to learn and yes, to have a good discussion wherever possible.
I will say that is your modesty. Yes, Dr. Darshan, you can start the history.
Okay, thank you, sir. I'm presenting a case. A 10-year-old Hindu female residing at Ranip, born out of non-consanguineous marriage, Hindu by religion, and coming from lower socio-economic class. My informant is a mother of the patient who seems to be reliable. Child presented with complaints of fever since 1 month, cough since 1 month, abdominal pain since last 7 days, and shortness of breath since last 2 days. Coming to ODP, child was apparently 1 month ago. Then she had complaints of fever on and off since last 1 month. Fever is daily since last 7 days, more at night, raid on medication, not associated with chills and rigors, and child is active otherwise when afebrile. Cough since last 1 month, wet in nature, associated with sleep disturbances, not associated with post-tussy vomiting, not associated with diurnal variation. And abdominal pain since last 7 days, umbilical in location, dull in nature, non-radiating, non-associated with oral intake. And patient is also having shortness of breath since last 2 days.
I think can you stop sharing? Can you stop sharing?
You have to stop.
Yes.
Darshan, can you stop sharing?
Yes, sir. Yes.
Stop sharing the slide, huh?
Hello.
वहीं से स्टॉप शेयर क्लिक करोगे तो आई थिंक हो जाएगा.
Darshan, please share.
Yes.
Yeah, fine,
हाँ
fine.
हाँ डन. हाँ.
Very good. We wanted to elaborate your symptoms which already you have put forward, and I think it is
Yes.
very interesting. Let me start. I think some other students are there from your place. Darshan, can you identify some of your colleagues?
One
Because I
second.
may not be knowing your colleagues.
Oh sir, nobody is from his institute.
Are
Okay.
there some postgraduates?
Or
There must be.
some other, Dr. Gunjan Ramani. He or she, sorry.
He's a EP from JMS Gandhinagar.
Okay. I think most of the faculties are more rather than the students.
Any postgraduate student in the session?
I think
Kindly
others
unmute yourself.
seems to be there. Please identify yourself so that we can have the good interactions, and you should not be afraid of it. Sometimes on the contrary, you should create the questions so that faculties are afraid
Yes.
of you.
One of my colleagues has joined just, Rakshan Verma.
Dr.
Rakshan Verma.
Raksha Verma. Okay, Rakshan Verma. Okay.
He left.
Even any person, but just if I am knowing, I can call the person by name.
Dr. Rakshan is there. He's there.
Right.
Yes.
But I think he has a connectivity issue, and it's like.
Anyway.
Okay, there's Dr. Kunal. Someone is
Kunal.
identified. Kunal
Yeah.
Jari.
Okay, Dr. Kunal Jariwala, very good. Please, even you can make your video on so that I can see your good faces.
Everyone, every resident, whosoever is present, kindly unmute yourself and make your video on.
Yeah.
It's a good interactive session.
That's good.
Please do it.
I think, let me know your others also. Dr. Parth Patel, any idea? Or I think Dr. Parth, can you introduce yourself?
Dr. Parth, please unmute yourself.
Dr. Sandhya.
Okay, and now I think Dr. Rakshan has joined. So you had some question for him,
Yeah.
right?
Anyway, Dr. Rakshan, I think he has started the story that he has the 10 years old female.
Yes, sir.
And that was the total duration of the illness according to his since 1 month. Dr. Darshan, is it right? 1 month?
Yes, yes, sir. Yes, absolutely right, sir. Yes.
Yeah. And he has given the sequence that first it was fever. I think let us see even the fever, some of the points he has mentioned. He mentioned more at the night. What does it signify? Is the important point or how will you take it? I hope the number, I will say pre-requisition, that is it really noted that more at night or just I will say in the history as we take, but I think let us rely upon Darshan that the more at the night, then what does it signify? How will you take it? Any
Okay, sir. So when
importance?
some diseases like tuberculosis have a tendency of evening rise of fever, nighttime fevers, and when I asked the patient history, they specifically told that at daytime child is active, but after evening the fever slowly rises, and at night.
So I
Yes,
think
she.
Darshan has revealed the diagnosis. It is tuberculosis.
Is it a documented fever, Dr. Darshan?
Yes, ma'am. 2-3 times they are documented. Otherwise, it is not documented. At home, not documented.
So Darshan, what I make the point that I think from the first complaint only, he has revealed the diagnosis. That it is tuberculosis. Is it right, Dr. Rakshan?
No.
Because he says that the most common this night fever is with the tuberculosis or anything else, Darshan, in your mind, some other conditions.
Nighttime fever. Or maybe it was like in daytime they were not much giving attention to it, and at nighttime they may be measuring it.
Anyway, suppose if I ask a direct question, how much you will give the importance for diagnosis or consideration of tuberculosis with the night fever? Or any when I would say generally, how will you take it importance to this point?
No, not specific, sir. We cannot conclude to diagnosis.
But would you consider the possibility? I will say you may not conclude the diagnosis, but you may consider the possibility Just
Yes.
from this point of view, I'm talking that the evening or the night fever.
One of the clinical features, so I might just take it into
Then,
consideration.
Dr. Lakshan, what is your idea? Whether do you agree with your friend?
Sir,
And whatever your stand, that should be with the explanation.
sir, as Dr. Darshan said, that fever during night time can be associated with tuberculosis, which is associated with the same. It can also be associated with malaria, which does not specifically present at
Dr.
night.
Lakshan, my question is very clear, and I think in the exam also, most of the examiners will ask a very precise question. Answer should be to that question. Not, I will say, as the politicians are doing in the debate. Right. Here the question is, night fever, would you like to give the importance for the consideration of tuberculosis? I will say not the diagnosis, but considering a possibility.
Yes, sir.
Okay. And that's why I asked the question purposefully. I think this is a tradition going on since long, but it has been found that it has nothing to do with the tuberculosis. Nothing given. It can be with any condition. Most of the times the reason is that with this very, I will say, Darshan was trying to give the explanation that severe mild to moderate fevers, probably parents may miss it or child may be active or so. And with the diurnal variation also evening or night, the temperature may be more and probably they will notice. So that's the only, I will say, importance to that night or evening fever. Not, I will say, peculiarity, characteristic of any condition. So don't, I will say, make that mistake, and I'm sure any examiner is going to ask you. Second, here he said that the with chills and rigors. Darshan, can you elaborate it that from the beginning is probably chills or rigors, or later on, or every time chills and
Yes.
rigors, or occasionally? Because this becomes a very important point.
It's a 1 month history, right? So whenever
Yeah.
you're taking a history like this, your onset, duration, progression, because a child who is having a history of 1 month, it should be a little more elaborate so that you get an idea. Was it, as sir is telling, was it increasing in intensity? What brought them to you after 1 month? So that should be a little more. You answer sir's question, then I'll just add some salient points which you have missed.
Yes. No, sir. Actually, there was not associated with chills and rigors. It was like that, sir. It
Not
was not
associated.
associated.
Okay, then it's
Yes.
all right. I think you mentioned with chills and rigors, or I think maybe our impression. Anyway, but fever was 1 month. Now, can you make it that whether it was from the beginning, any degree of intensity of fever, whether anybody has measured? May not be probably by parents, but then in the hospital or somewhere. And then what are the pattern? What are the intensity? From the beginning it was high grade or low grade, gradually
It has not
increasing.
been mentioned. You did
How
not.
many times? I will say in
Okay.
a day. What was the response to the antipyretic? I will say, any symptom, then you'll have to elaborate in details. As exactly Madam said, that suppose fever, it is documented. We need to make the point clear so that in the exam, your time is not wasted. That's suppose documented. You can say that suppose parents did notice or not documented, but later on in the hospital and mother was told this degree of fever this many times, right? Whatever the suppose spikes, numbers of spikes in a day, and then what are the response to the antipyretic? Even suppose the mother is knowing which antipyretic was given, and most of the times now the parents are knowing even that which drug was given for the fever. And even chills and rigors and anything, and then probably we can go in the details. But 1 month fever is very, very important that we'll have to go in the details. Darshan, now with that idea, can you take it again? Whatever suppose points are there with you. If you're not knowing, no problem. Please don't bother.
Yes, sir. History was from 1 month, but it was initially intermittent on and off, sir. And they were not documented at home. But after 7 to 8 days of fever, initially they visited OPD-based treatment, and they took antipyretics, and fever was relieved, sir. Then what brought our institute was, since last 7 days they are having daily fever. Fever was relieved with medication, but not reliever medication, but was like daily fever. They have to take paracetamol 2 to 3 times per day, and
Okay.
1 to 2 times measured it in OPD was 101, 100, 101 fever was there, sir.
Okay.
Not exceeding that.
Even it is also very important that what are the condition of the child during interfebrile period. Whether suppose already you are given the antipyretics, fever has subsided, really fever subsides I will say to normal or remains sometimes some degree. And then what is the activity, appetite, or I will say
That was the next point I was
condition of the child with the fever. Any idea?
Yes, sir. Initially, the child was active during of a bell period. Since last 2 days, there was weakness and shortness of breath, and that since that child was not active.
No, and the
Good.
other thing, Beta, that shortness of breath for 2 days, this is in your chief complaint also. And when you are describing your history of presence, what do you mean by shortness of breath, right? So shortness of breath cannot be only short. It has to be either in the rate or in the difficulty level.
Yeah.
All those things, but suddenly a shortness of breath comes in a child where it is fever, then this shortness of breath has to be taken seriously, and the description, we don't know, was it increase in rate? Parents will always tell, तेज तेज सांस ले रही थी, गड्ढा पड़ रहा था, something. If once you have taken the chief complaint,
I think, madam, we are.
Okay,
I think we'll go with the chronology what he has given, then probably more the clarity. We'll come to the point. Yeah. So I think the second complaint what he has taken is the cough. Again, the cough, I will say there are 10 to 11 points, which always you should describe in detail. Suppose the examiner is not interested to know, he will say, okay. But we'll have to present, I will say methodologically. Suppose cough, what was the onset? Duration, I think, okay, you said 1 month. Then what are the type of the cough? Even during sleep, what was the situation? Severity was same or progressively increasing? The progress of the even symptom also. In between, sometimes 1 month. Many times parents will say 1 month. But if I ask, they said fever, cough was there for 5 to 7 days, it subsided, it remained all right for 15 days, and then again the cough. Then I think my thoughts will be different.
Yes.
That may be the recurrent viral even. Nothing it has to do with, I would say, I may not give them much importance if the apparently child is normal. So that, and even this, suppose some drug is taken, suppose some bronchodilator is given, somebody has. What was the response to that medicine? So all the points or some aggravating or relieving factors. So even the weight cough, you said, what do you mean by the weight cough? Dr. Darshan, let me go to Dr. Darshan. I think, Darshan, you can have some time. Dr. Darshan, what do you mean by the weight cough?
Sorry, sir?
What do you mean?
He said that it was the weight cough. What do you mean by the weight cough?
Okay, sir. Sir, weight cough is kind of a productive cough in which, like you mentioned, that fever is for 1 month and there is also shortness of breath. So that could be due to a lower respiratory tract infection. Duration being of 1 month, it is a chronic.
No, Rakshan, always be very precise to the question. Weight cough, what do you mean? Suppose some mother is talking to me, there's a cough is there, and some, I would say, sound is continuously coming up. Or mother will say, very simple in the Gujarati, gasta hai, right? I will say, madam can also understand that what we are talking. But the parents will be talking in this way. There's some gargar aisa sound aata hai, and she says it is a weight cough. How will you take it? Expectoration is different. This is different. Of course, if the complaints of weight cough and 10-year-old girl, yes, you can go in the details of expectoration also. So, Darshan, what was, I think, let us go to Darshan. He may have more information. Can you, I will say, address to these points in the cough?
Child was, sir, occasionally expectorating sputum. So I included it as a weight cough, sir. Okay,
but then you'll have to go in the details. That suppose occasionally that what occasion, and then what the, I will say, sputum content, color or something, or just I will say it was spitting. So what is your, I will say, interpretation? Any idea? Suppose if you have not taken detailed history, no problem. You can say simply that somehow I have not asked or I was not aware. Because every time we may not be knowing everything.
I was not aware at that time.
Yeah, and our aim is we can learn from the discussion. That suppose next time we have to present or even next time the patient comes, we know all these points, even all of us. That's why I think cough, usually better to go in this way and somebody is going to take the in details. Because in pulmonology, cough is very important symptom. It is said that many a times when you can suspect some condition, some important clues if you get in the history. Suppose I will say the 2 years old child. I remember when I will give the real scenario, long back I came across, probably 1.5 or 2 years. Child was brought to me for this booster dose of the vaccination. Child was absolutely fine when I examined. Around 1:30, that booster doses were given. Mother went at home. And 4 o'clock she called me that the child had very bad cough. Suddenly started and very bad cough. And before that, naturally, 2-3 years, I will say 3 hours back, I examined that the baby was fine, no complaint, and therefore I given the vaccine. And suddenly, mother says that this cough has started very bad, not even be able to remain silent for some time, and constantly, and suddenly started. What will be your first impression? Darshan?
Any foreign body aspirations?
Very good, very good. I will appreciate you. And this is our purpose of, I will say, discussion. Suppose if you listen and once a while same patient, similar patient comes to you, you can diagnose. I asked the mother in the details that after the vaccination, child was crying, remained calm for some time, slept even for 1 hour or so, got up, I gave something to the child to eat, and then suddenly I said, what did you give? She said that usually this is my time to offer some dry foods, and something like that. Question it was given. And this is so sudden, this type of the cough. Similarly, usually neonates, I don't expect the cough because they don't have the mature cough receptors. But any neonate, suppose presents to you with a very bad cough, what importance you will give? Which conditions will come to your mind? 20 days old child. And mother says very bad cough. Sometimes remain silent, okay, but starts, then it continues for some time.
Things I know, many.
Yeah, madam is giving more hints to you.
I've given more hints.
Patient have TF.
Very good. Even TO fistula can also present. But that will be very different, even cough and some recurrent pneumonia. But I appreciate you. That any malformation that may present you with the cough. Anything beyond that, it is infected disease. I will say vaccine preventable disease. And as madam said, yeah, if you ask the history, even older sibling is already had. So that's the pertussis.
Pertussis.
And that is the situation why you should, or even sometimes aspiration syndromes can also play. Theophysiologized aspiration or GRD or something like that. So what is our idea? That this is, I think, well-known one study, which even I have put in my book also, and that type of OSCE also was asked, I will say, last year, that there are the 3 different types of the coughs. It was studied in some African country. That cough starts suddenly or acutely, not suddenly but acutely. That acute cough. And gradually it decreases, but continues for even the long time, prolonged time. That is one, I will say, way of presentation of one group of the patient. Second patient complains, healthy and hearty, develops suddenly cough, remains, I will say, for 3-4 days or even after the treatment, getting the relief. Again, at certain intervals, similar cough develops. In between, child is absolutely fine. That is second group of the disorder. And third, cough started, gradually, progressively increasing, never decrease, and continue to increase, and now more than, I will say, 3-4 weeks or more than 2-3 weeks. What will be your interpretation with the different 3 groups? Anybody will try. I think this is going to be very important in our practice also. Anybody? Can this one?
For acute.
Yes, Darshan, I think you can take it.
For acute first group, we can go for any foreign body. The second group, we
I will
said
say
there was.
listen to me. It's not suddenized. It's acute. Remain for 3-4 days very bad cough. Now gradually decreasing, but continue for 7-8 days or 10 days dying.
It can be to URTI, post-viral URTI cough.
Very
can be
good,
there.
very good. You are knowing it's a viral. All of us know. Very common presentation or daily practice. Fever or cough, cold. Cough starts acutely, very bad cough particularly, remains for few days disturbing. Then mother will say, yes, sir, it is decreasing. Most of the patients will recover in 4-5 days or 7 days. But if it is more than that, it looks like viral, but remain for longer time. Then what will be our interpretation? Viral, but which virus is what I mean to say? Commonly, I will say, I will give the explanation to the mother that this is viral. Within 3-4 days, it will decrease. Then in 5-7 days, child will be all right. But comes to me back after the 10 days, 2 weeks time. Sir, you said, but still the cough is there. Of course, it is decreased, but still it is there. Common, the respiratory syncytial virus, adenovirus. In that case, even the cough is prolonged. So it's an acute cough, but prolonged cough. And that happens with the viral. Intermittent, for a few days and then recovers and then again develops. That, very classical example of bronchial asthma. And at times, if you go into the details, may not be the fever or fever may be the mild, is not important symptom. Maybe associated sometimes breathlessness. Every time breathlessness may not be there. These all variants of this bronchial
Lots
asthma.
of other symptoms like night cough, history of atopy, family history.
This is very common.
Okay.
And particularly, the cough started gradually persistently increasing and never decrease. And now 3 weeks cough. What will you suspect?
Any parenchymal lung disease of lower respiratory productive?
Why any parenchymal? On the contrary, please remember, parenchymal diseases are lesser the complaint of the cough. Because cough receptors are not, I will say that.
Airway involvement, bronchiectasis.
Bronchiectasis, again, unless that material comes the sensitive area, cough is not the problem, more of the expectoration. But it is, I will say, yes, Dr. Shalini has put it very good. It's a persistent, non-remittent cough. That's why I will say, remember these two adjectives. Another thing in the medicine, better to find out the appropriate words so that meaning is conveyed. Somebody may ask you the question in some other way that qualify the cough for this tuberculosis. Then I will say that cough gradually onset, but it is persistent, non-remittent cough and more than 2 weeks time. That's, I will say, that's why we say this is a qualified condition for consideration of tuberculosis.
That's what your algorithm also writes, no?
Exactly. Actually, what I want to convey to all of you with these illustrations or examples, in the medicine, I will say undergraduate students in whatever way describes, I will patiently listen to him because I'm not expecting much. But from the postgraduate history, it should be very intelligent history. My every point, what I speak, is conveying some meaning, exact meaning I'm conveying. With that idea, you should speak.
It should lead you somewhere.
Yeah, not I will say just from the standard given textbooks descriptions. So that, and it makes, I will say, different your way of presentation. It becomes impressive and meaningful discussion. I think here you said the cough for 1 month, right? Can you just elaborate it? 1 month cough. I'm sure that Dr. Sonia is going to ask you. So before she asks, I am helping you.
Yes, sir.
Any details, whatever you are knowing, no problem.
Yes, sir. So the cough was since last 1 month, sir. Cough was not non-remittent, sir. Cough was progressively increasing in intensity, sir. And initially was able to sleep, but later on stage the child was sleep was disturbed, sir, due to constant coughing, sir.
Right. Disturbing sleep, it gives you the idea of severity. That is another thing. How I will take it? That either some condition, particularly in the lying down position, probably it is aggravated, I will say post-nasal drip, sometimes sinusitis, some aspiration, GRD-like condition, or even the asthma, what we said. So, this will give you the idea. So, or otherwise, probably the cough is started gradually, but now even disturbing night, that means the severity. That means now it has increased in severity. And then persistent cough, I will understand that whatever the, I will say, offending agent, or some, I will say, whatever the pathology, it remains constantly. That may be in the form of, I will say, suppose some irritating to the airway, that means compression, maybe from outside or inside. Inside, maybe the endobronchial some problem. Outside, some mass or lymph node or something, or vascular ring, or whatever I will say according to given scenario, I may think. Maybe the lymphoma, maybe tuberculosis. These are the things should come to your mind. So this is, I will say, here you said cough 1 month. That means it is very important. What I want to, that every symptom you go in the details. Then, we are getting various dots, 1, 2, 3, 4. Join the dots. If you join the dots, it gives some picture. That, oh, this is the fever of 1 month. And now if you say the abdominal pain, 7 days. Let me go to others. I will say everybody should participate. Then how will you take this? I will give the details what Dr. Darshan has said. Somebody joined late. Dr. Shalini, because I hope that you are responding very nicely. He said here the fever was 1 month, cough was 1 month, but now abdominal pain 7 days. And Darshan, can you give some details of the abdominal pain so that Shalini and all others even can think?
Radiation, everything.
Whatever
Yes,
the information you have.
Pain was since last 7 days. It was peri-umbilical in location, and it was non-radiating and not associated with any oral intake. And,
Okay. Now, how will you give the importance? Dr. Shalini, please come on. You should answer. Yeah. Whatever your interpretation. Good. I will, at least somebody is, I will say, making the video on. That is a good courage. And once you start to speak, I will say half of the battle is over. Whatever you answer. This is very important, I will say. Even in the exam, same thing. Even answer may be wrong, but at least you are trying to make the attempt. That's good. So, Shalini, how will you take it? Because he said that the fever and cough 1 month, but now the patient has abdominal pain. He described somehow that 7 days time, peri-umbilical. How will you take it? Is it related to that respiratory problems which you are thinking, or something else? Or you have some link between these two? I'm just giving the idea.
So because of chronic cough, it might be possible the abdominal muscles must be in pain because it
Very
is
good,
of
I will
all
say. Most of
unknown.
our parents will give the explanation.
Yes.
Sometimes parents, when you are asking the history, they are giving even the diagnosis also. That this pain in the abdomen is probably because the cough is since long duration. There is the, I will say, exertion of this abdominal muscle. But do you expect that pain will be peri-umbilical?
No, sir. It mostly is subcostal.
Because, most common muscles coming the action with the cough, even diaphragm. Of course, very vigorous cough even. Abdominal muscles are also going to be in action. So maybe, I think here in this, but suppose, Darshan, you are sure that the abdominal pain was peri-umbilicus and nowhere even in anywhere else?
Yes, sir. As far as I took history and
anyway, let us take that Darshan is right. But I will give the another scenario in some other way. That another patient, I'm not talking of the same patient, another 7 years old child, started with the high-grade fever, mild cough, and even the fast breathing, and complaints of the pain in the abdomen on the right side. How will you take it? How will you try to explain this pain in abdomen? And even if I reveal you that somebody has gone for the X-ray test, and that helps me to explain even this abdominal pain. Started with high-grade fever, cough was there, but not the prominent or the chief complaint. Chief complaint was the fast breathing. Child was a little bit toxic also, febrile also. and also the complaints of the pain on the right side of the abdomen. And when I examined, I got that the pathology is also on the right side of the chest. Then how will you explain? And somebody has gone even the chest X-ray also. What you are expecting here? Or how will you explain the pain in abdomen with this pathology or problem? Anybody? In other way, if I ask a direct question, rather than to confuse you, can you give some most common cause for chest pain due to the respiratory cause? I will say give the direct question in this way. Very good. Dr. Shalini herself said pleural effusion. Rather than effusion, we should say the pleurisy. Once effusion is there, probably this pain may disappear. But yes, pleurisy can cause. Suppose if it is not pleurisy, something else?
I think I gave the answer. If you have listened, they've listened.
Sometimes it happens that next examiner will answer if the student is not answering. Even sometimes the same pathology may cause the shoulder pain also on the right side. It is the lobar pneumonia is common.
I think they missed.
Yeah. And suppose right upper zone pneumonia sometimes may cause even the shoulder pain or even the abdominal pain, or sometimes even the irritation of diaphragm can also cause the shoulder pain. That the phrenic nerve supply. What I mean to say that always going this way. So here I think abdominal pain 7 days. We are not sure. Maybe probably let us consider that maybe the symptom associated with the pathology, or we'll try to see is there any link either with the pleurisy or pneumonia or something respiratory, that means pathology is also responsible for abdominal pain. At present, we are not sure. So let us keep in this way, the same it is. But now you said what Madam was asking, shortness of breath. Up to what do you mean by the shortness of breath? Please, I think another thing, what Madam was trying to make the clear. And I also said, whenever you speak, find out the appropriate word. Just don't use the loose terminology, because it decreases my, I will say, weightage of presentation. I want to create impressive presentation. And for that reason, find out the selective appropriate words.
And this is a very important complaint which has brought this child to hospital. 1 month not come to you. So this is a concerning thing, right?
That's another thing. Very rightly, Madam said.
This is the one thing which should be taken in very much detail, right?
Yeah. What problem brought the child to you? The problem was going on 1 month. And here probably the acute problem, I would say bothering or disturbing problem to the parents and to the child is the breathlessness. Therefore, I think you should take it in a proper details of the breathlessness, because it can be the dyspnea, different thing in a case, cardiac cause. Yes. Here maybe the simply fast breathing, or maybe the fast breathing with endurance or something. So all the points, I think you should go in the details.
In any case of when you're using the word shortness of breath, not
the I think, Madam, you can take it, elaborate this point of shortness of breath in details, please.
Breath, So a few points. You've taken it everything well. One thing in this, initially when you are giving patient initials, you told 10-year-old child. So not for this case, for any case as a pediatric post, 10 year is not the word. You should always be telling in ideally decimal age, but even if you're not telling, please tell the date of birth. How she's 10 years? Mother told 10 years? No, because once you take the date of birth, everything will change. Her age will change. Her calorie requirement will change. Your marking of growth chart. You can't mark a growth chart without date of birth, right? So make a habit of child born on this date, 9 years, 7 months. Maybe she's exact 10. Then also we'll know that you have taken in detail. So that was one thing which I noticed you have taken there. Other fever, and every cough has been taken in detail. So shortness of breath, as me and sir both told you, that this is the complaint which has brought the child to you. So what kind of shortness? In any case, shortness of breath, you should ask, is the child, first thing is, what is shortness of breath for the parents? Is it breathing faster than usual? There can be two things. When they tell hurried breathing or difficulty in breathing, whatever term they use, it can be either he's breathing faster than usual or he's having harder than usual. दो चीजें हो सकती है, either he's tachypneic or he's dyspneic. So both the things you should ask. So then you asked, mother says that this child has developed difficulty in breathing or hurried breathing last 2 months. The mother says that she noticed that the child is breathing fast. She also noticed some indrawing or whatever she's telling you. Or probably she was sleeping comfortably. Now she's not able to sleep. She's sitting. That can be a thing. She can be breathing fast. She could be seeing some chest indrawing. She could be seeing this shortness of breath in till yesterday, till 4 days back or 7 days back, this child was playing with friends or at least sitting. Now she prefers to sit. So many things should be asked in shortness of breath, right? So one is progression. Again, everything goes with onset, duration, progression. So onset, it was sudden onset. The way you say that she was having cough suddenly. So all these points should come. Okay. So this is one important thing which I would like to mention. Another important thing which I would like to mention is, I don't know if you have, because that when you are showing to us, you move to the negative history or whatever you have taken. So in a child of 1 month old, itna lamba illness hai, so please take a good history of how the appetite and activity. You can make, mother may not tell you, but at the end when you have taken shortness of breath for these complaints, then you have to always ask how was the appetite over 1 month, how has been the appetite of the child, and she will definitely tell ki doctor sahab itne din pehle kha rahi thi ab khana chhod diya. How has been the activity of the child, which sir also told that. So even if they are not telling at the end of itna lamba history, 1 week, 5 days, even if you don't tell, chalta hai. But in a 1 month history, even if the parents is not telling, please take into account activity, appetite, urine output. All these things should come in account when you are presenting a history of present illness, right? Sir, any comments?
Yeah, fantastic. I think now what is my idea that from the history only, our aim is to think that what is the anatomy? Where is the problem to this patient? That's why always another thing what I always use the word, when the parents or the patient starts to speak, our thought should be in action. Not, I will say, just passive listening. That every word, what they speak, is very important for me. And sometimes from that, I will decide the next question for more clarification, for more elaboration. And then it will be probably more clear to me, more meaningful. That will give me more, if I will say, bright ideas that what should I consider. So history is really, and probably your CT, MRI may not be able to answer. But my this, I will say, thoughts should be able to answer. And suppose if it is not tallying with my thoughts, I will go back to the history. That's something I'm missing. This is really beauty of the history, and that really is always rewarding. Now, what I want to make it, as I say, that suppose my granddaughter is there. Sometimes she tells me that draw some animal or something. For her age, she is 5 years. What I will do, I will make one circle, one bigger circle, then some small, and then some lines. And then if I join it, that becomes the head, that becomes the larger, which is the trunk, and then I will say some points, or I will say lines, that is the legs or tail or something. Whereas I join it, it gives the picture of the row. This is something like dog or something like some animal. This is here also, we have some dots. Fever is there, cough is there, breathlessness is there, right? Or fast breathing is there. Now, if you put all these symptoms together, you will realize that where is the problem. Similarly, something I will say many times I ask in this way, that why the respiratory case? Because you have given the title respiratory case. I will consider it's a CVS case.
Yes, still we cannot say where
I will say it's a CVS. But from which, suppose if somebody even say, you may not be always right. But how will you try to justify that it is more likely the respiratory? Anybody? From this our discussion. Suppose some respiratory CVS case, then what will be the presentation of that case? Yes, Darshan, very good. Please.
So due to temporal progression of the symptoms, initial cough was the early symptom, and in the later stage there was shortness of breath.
Very important point, the sequence of symptoms and chief complaint. That becomes here the cough is very prominent, the way which you describe for 1 month. Right. Here seriously what happens, the fast breathing comes fast. And then the cough comes. And the cough is not the major, I will say, complaint. Maybe associated, but not, I will say, bothering much. But the fast breathing is bothering much. Then, of course, rest of the other thing. But I will say, just you can make the impression. This may not be every time right, but most of the times it is right. If you go in thinking in this way. Now, if we try to make the anatomy, here the cough is vein, that means airway disease. Whatever the problem, but airway is involved. And that airway problem, if you remember the cough receptors, maximum in the pharynx, right? Then the larynx, then the airways, larger airways, smaller. As you go down, even the airways, cough receptors decrease. Suppose tertiary, even the tree of this bronchial tree may not be having the much cough is the problem. Upper, yes. Even the pleura is having I would say the cough, J receptors even in the lungs also, but they will be mild.
And
even the ear also, the cough receptors can be there. So, sometimes cough is there, maybe due to the various reasons, and that will help us for the thought when very simple, easy problem is not there. So here now the cough is there. Then whatever you said, fast breathing since 2 days. Now, if you put together, that means it's a respiratory case, probably start. And another thing, fever indicates some infection, inflammation or infection. Here, probably infection is more likely. So, some infection involving the airway, probably with the progress of the disease. Now, it has also probably reached to this lung parenchyma. And the child is breathless. Or probably as a problem or complication, involvement of the pleura, and therefore even the pleural effusion or something develops, child becomes the breathless. That may be when the short is cured, so with the problem or complication. This is one way of thinking. Or even as a clinician, we have to keep the mind open. That's why Madam said that you should go in the details of the breathlessness or something. So a child complains that breathlessness is, I will say, some 7, 10 days, 50, or sometimes in chronic condition, even months together. But here the child is able to walk. After some time, he has to sit down to take rest. Again, even walks. And when I examined it, the child SpO2 is low. And even the clubbing also. Problem is respiratory cause. What will be the anatomy? If I remind you, there are 4 components of main anatomy in lungs. One is the airway, second lung parenchyma, third is the pleura, fourth is the interstitium. If I put the MCQ that out of these 4, which one is more likely in the given case scenario? That the child is particularly having this breathlessness, getting some relief after some rest, and then able to walk. But on examination, somehow it shows even the low SpO2, oxygen saturation is low, and even clubbing is appearing. Then which component is likely involved? Is it airway disease? Very good, Darshan. My interstitial, very good. Here, can you give now one example in the practice where the interstitium is involved? Infectious disease is common in India.
Viral pneumonia.
I said common in India. Of course, viral is also common. But some chronic infection.
Chronic infection, and yes, and we have
chronic infection.
Investigated so many places, but
even on chest X-ray, that may be the diagnostic sometimes. In such a patient, if you're gone for interstitial lung disease, which one, Shalini? I'm talking some infection. Interstitial lung disease, you are right. But interstitial lung disease, many conditions. But here, tuberculosis, miliary tuberculosis. Miliary tuberculosis is interstitial lung disease due to tuberculosis. And that patient usually presents in this way. What is my idea? To give the broadly, we'll have to think various situations. So I think here from the symptoms, we have taken only first slide, Darshan. That is the beauty of the medicine. Only from the first slide, we have discussed probably almost 950 that means almost 45 minutes. And most of the things will be, I will say, revealed. It is a respiratory problem, probably started with the infection, airway disease. Disease has even progressed probably, and we are not sure, but whether they involve to pleura or even the lung, or of course even the nutrition, or sometimes multiple components can also be involved. So that can be revealed later on. Right, but I will appreciate you, Darshan, that you have put, I will say, symptoms first slide also very nicely. And it's a good thing that we could discuss so much from your, I will say, and Madam also elaborated some of the things, very helpful to us. For, our aim is not to discuss one particular case. Our aim is to learn the medicine. Here probably we have selected the pulmonology. So let us try to understand as a general pediatrician. Of course, for Madam it is very superficial. But I'm sure that for general pediatrician, this is very important, sometimes more than sufficient. Okay, Darshan, I think now again you can share the PPT and take the history part in details early.
And Darshan, quickly, if you can tell activity, how was the activity weight?
Yeah, that is also very
1
important.
month. Quickly, you tell us. You have not written there, but how was her appetite, weight, all those things? Or is it coming in the next slide? Then you can cover in the next slide. Fine.
Appetite was reduced, and 4 to 5 kg weight was there, which I mentioned in the next slide. And last 2 days, child was not very much active and preferred sitting down.
Share your slides.
Okay. Yes. I think again, this is the increased work of breathing, if you say. But I think on the examination, we'll go in the details. At present, you can take it further.
There were no complaints of any bleeding in cuff. There are no complaints of any.
Sorry, Darshan.
Darshan, your slide is not visible. Your slide is visible, but you have to reach to that slide.
Not appearing particular slide.
Yeah.
Okay,
Start slide share.
Yes.
Very good. Can you make it?
So Darshan, that's why I stopped you. You have not told here because I could see the next slides were negative history. So what I'm talking about is appetite. This should have come in the first slide itself. If it is then it supports so much. No, so if you are telling weight loss is there, that would have supported so much, like reduce appetite, and you are telling weight loss. So that should have come when you are describing your history of present illness at the end. Correct? Okay, you can proceed.
Yes.
Here we don't get any idea that what was happening. No, this is just a negative history. Okay, understood. No.
Yes, ma'am. Got the point. Yes, ma'am. There was no complaints of any bleeding in cuff. There was no complaints of any ear pain or ear discharge. No complaints of any burning micturition. No complaints of any neck rigidity or abnormal movements. There was no complaints of any altered sensorium. No complaints of any loose stool vomiting. No rash. No history of rash or. There was no history of allergy.
Darshan, Dr. Chirag reminds us to show some third slide. So I think it's the same thing. I think from this you stop it, so it's right. Okay.
I think you skipped one slide, no?
No, he is not skipped.
No, I think he's right.
No, yes. Not shifted.
Yeah, I think from this point you stop it, so now it's a right slide, please. Yes, sir. Go ahead, please. Sorry to interrupt you. You are right.
Stop sharing or go ahead, sir.
No. You can make it full screen.
Now it's full.
Yes.
You can make it full. Yeah, very good. I think, Darshan, to save the time, can you give the explanation for each your point so that we can save the time? Suppose no complaint of bleeding in cough. What you want to convey?
So there was no any trauma to the airway, or there was no any hemoptysis as such, which can be present in conditions like bronchiectasis, tuberculosis, any airway trauma.
Darshan, I will tell you. Here, why I should mention the trauma. The presentation of trauma will be different. It will not come with the fever, cough, and in this way.
No, yes, sir.
So we should. That's why I'm telling you. Whenever you speak, it should be very precise and concerned to your case, so that ultimately at the end the story is very clear. Here, I think if you say blood, and that rather than bleeding, blood in the sputum is different. Not even the cough. Right? Not even the cough. You should say blood in the sputum.
Yes.
That's why I will use the appropriate word. Cough is reflux. Reflex. It's not I will say. Blood will be in the sputum, in the expectoration.
Yes.
Right. So that's why I would say the parents may talk in any way, because for them cough includes everything. They will simply use the word. But here I will say that's why. So there is no hemoptysis, right? What is the ear
Yes,
pain and ear discharge? What were your importance?
so, sir, the long history of fever and cough, and as we know, cough receptors can be also in ear. So, any suppurative otitis media or any condition like this, so
Not in
I
10 years
tried.
old girl. This is
Okay.
not the situation for 10 years old girl.
Yes.
Right. That's why I will say. And even this long duration will not present with the ear discharge even in the younger children also. That will present with the otitis media.
Correct.
That symptoms will be different.
And rather than bringing out neck rigidity is not a complaint. Parents will not.
Yeah,
And
parents are not going to. Even what is the importance of burning micturition in this patient?
And the other important thing is, sputum, cough in blood in sputum is a very important thing which you've asked.
Yeah.
You should, as sir told, it could be CVS, it could be C. So she has come with sudden onset of dyspnea or breathing difficulty, whatever you want to say. So you should try to rule out the cause. Was it a cause like CVS? Was it respiratory? So if the history of dyspnea, orthopnea, all those comes, it will be more relevant than bringing this neck rigidity abnormal. You just come and we'll just tell you how.
I will
Yes,
say,
yes, ma'am.
let me go. No, even Darshan, you can say very frankly. Please don't hesitate. Right. So
Yes.
what are the idea of burning micturition?
Sir, so I thought the last 7 days she had developed abdominal pain. So I thought initially that was a URTI and this was newer complaint of any
10
UTI in a female.
10 years old girl will not complain of abdominal pain for the UTI.
Periumbilical. It was periumbilical.
Yeah. On the contrary, if at all she has the cystitis, which is common, suppose if at all UTI, the lower UTI. And in that case, the symptoms will be different. Lower abdominal pain, burning or something. That's why I'm telling you, don't give I will say, space to the examiner.
Yes.
Because I will say, takes your time. And second thing, I will say, quality of your presentation. So don't give and suppose even in the negative history, don't mention unnecessary point, which is not relevant to my case. Right.
Yes.
So here I will say, as Madam said, absolutely, even the neck rigidity, abnormal movements, I am not expecting, not relevant to this case.
And please don't write neck rigidity in history. You examine neck rigidity, right? Your parents will not tell me your neck is rigid, right? So it should not. So in this case also, neck rigidity should not be written in.
Another thing, if the ultrasensory, even hypoxia can cause it, but in that case, what happens? Ultrasensory is not that it is as a negative, that parents will make complaint because it's a main. Ultrasensory is not that it is the soft complaint. It's a main concern.
Yes, sir.
And my child is not responding. So it is not going to negative history, and you are not mentioning the chief complaint, that means it is not there.
Not there.
It is not there.
Yes.
Right. Loose stool vomiting, okay. I think that is also in acute history, not in this 1 month story. Rash, okay. Allergy, again, probably it's a victim, better to remain away. Right. But good points. Okay, take it.
You could have mentioned there is no history of recurrent cough and cold because it could be an acute history. It can be a history of 1 month. It could be the parents have come to you at 1 month and they have admitted her earlier. She has a recurrent history. So rather than allergy, if you could have written that there is no history of recurrent cough and cold or something, that is still better than writing allergy, right?
Yeah.
Yes, got the point. Yes.
Again, Darshan, that's why I'm telling you. We should be always, all the students, because I will say Darshan is presenting, that's why I'm addressing him. But this is applicable to all of us and even all the students. That whenever you are presenting, allergy is a very big chapter, very big issue. Yes. In what way allergy, I will say. So if at all it is concerned to that, if you want to ask, as Madam say, some recurrent symptoms. If something is recurrent symptoms, probably may be related to this hypersensitivity airway disease or something you can take in this.
Exacerbating factors. There is no history of bleeding in sputum, blood in sputum. Yes. At that point, you can say there is no history of night cough. There is no history of any exacerbating or relieving factors. There is no history of recurrent cough. Then come to the rule out it, differentiate it from cardiac, because these are the two confusing things. That whatever there is no history of dyspnea on exertion, there is no history of orthopnea, and then whatever you feel is very important. So it is like cross-examination, what parents have not told and you think can be a DD, those are the questions which you ask. Nothing, and not like in a book it is written that sab kuch lena hai, to humne sab kuch पूछ लिया. It should not be like that, okay?
I think for negative history, I have told several times, again I repeat it, negative history points should be selected related to your case. That presence or absence of that point helps me either to strengthen my possibility, the condition which I am thinking. It helps me to think. Or second, it helps for the differential diagnosis of nearby differential conditions. And third, which is expected complication in that condition, and whether that complication is there or not. That suppose a case of jaundice or liver or something, I want to say whether hepatic failure is there or not. So no signs of liver failure, that gives them the exact present status of the liver functions. That's why I will say, even somebody mentioned no signs of respiratory failure, that's good. Because with these one, there is the breathlessness and everything, whether the child has gone to the severity. So something I will say related to our case, that should be the point should be selected in the negative history. Okay.
Yes.
Please go ahead.
Coming to past history, the child was a similar complaint of coughing lasting for 1 month in March 26. And according to parents, some blood investigation, radiologic investigations were done. And they took OPD-based oral medication. And after the child has improvement. And
One second, Darshan, I would like to stop you here. So coughing lasts for 1 month in March. So this is different episode and that was a different episode, you want to say?
Yes, in different episode. Patient came to June 2026.
Asymptomatic in between somewhere, if you are bringing it in the past history?
Yes, ma'am. Patient came to our institute ending of June. So since beginning of June, she was having complaint of cough. And also there was a history of coughing.
Episode, then April, May, she was fine, and June it started again?
Yes, history was like that, ma'am. Yes, ma'am. From parents. Okay. And
I think Darshan, what I want the clarification.
Yes, sir.
That in the March 26, that means few months before, 3 months before, I think, before coming to you. Am I right? Because you said June patient came to you. So 3 or 4 months, whatever the time. And during that time, you should go in the detail that suppose here you said that cough was there. Was there fever or not? Then suppose whatever the investigations were done, and then you can ask the details whether the treatment was continued for long time or for short time. What was the real advice to the parents? Were advised for the long time, suppose like the antituberculous therapy, but they stopped by their own.
Was it a failure or something?
Or really it was, I will say, pneumonia or something, and the consultant advised to stop after 10 days or so. So what was the real story?
This changes.
That we should try to dig up. And that will be the very important point. Of course, and this information can be available from the parents.
Yes. So parents are told us that in March 2026 they had complaint of fever predominant, cough predominant. There was not much fever, but then they visited private practitioner and there they undergone blood radiologic investigation, and they also verbally said that doctor said that there was a pneumonia and they got oral amoxicillin as far as I remember, but there was no documentation. It was a short course, 7 to 10 days.
Right. This makes a difference. This is very important information. Good. How I think we can link that will go there after some time.
Even history of losing 4 to 5 kgs. This is in March or this is in now when she has presented to you, this 4 to 5 kg?
No, ma'am. I should have added this topic in the earlier slide.
Right.
It was history in last one.
So this is in this present scene only, no? Right? That's how it.
Yes. Another thing, this weight loss, was it documented?
Yes.
Just impression of the parent, because otherwise every mother is having this complaint.
Otherwise, they lose or is the major thing, but if they have documented, it's a very significant
thing. Because suppose documented, that means you have, I will say 3 months back, at least in March, you must have some weight record, because consultant has seen. In between, suppose available, it is okay. Otherwise, you can note it, and really, if it is documented, and 4 kilogram weight loss in 10 years old girl in 1 month time, that I will say gives very significant point. I may make it bold. I may even increase the font size. even I will tell to the examiner that please listen to me. Please listen to me.
That's how I was pointing that
I will say that's the way how we should make it. But at least we have noted it. Okay, go ahead. I think at this juncture, suppose anyway, I think better you finish, then we'll go because I will look at the time also.
Yes.
Okay, sir.
Yeah.
Coming to antenatal history, there was no adverse antenatal event, and all antenatal visits were done. Birth history was not significant. There was no history of any NICU admission. Child was immunized up to age, and BCG scar was present, sir.
Again here, please use the terminology properly. Immunize up to age, what schedule they have followed. Whether the National Immunization Program or whether this, I will say IAP recommended vaccines, which they have completed.
And the best way is last immunization received, because that will add objectivity. Either they have immunization card or you say, "Aapne kab lagaya tha?" Many times they'll say immunized, lag gaya tika. But when you ask them 10th year, because she's 10th year, so aapka kab lagaya? 5 saal pehle. So that always should come there, if possible, to have a card. If not possible, please document the last immunization. That much they will remember. They'll not remember 16, 14, but उनको हमेशा याद रहेगा कि मैंने 1 साल पहले लगवाया था या 5th year पे लगवाया था. Okay?
Yes, yes.
This is, I will say, in the exam point of view I'm talking. Don't use this terminology like immunization up to age or like that. What mean by the up to age? Okay. That's very important. Even suppose if you can, even shortly, if I want to present, you can say that the last vaccine was given at 5 years according to National Immunization Program. Okay. And they have not gone this vaccine, other vaccines beyond that. Otherwise, sometimes nowadays, according to national program and some other vaccines, they will go to the private practitioner. So both the things will have to join, really, if they are followed up. So all this clarification should be made, please. Okay.
Yes, yes.
Suppose if I ask the history, Darshan.
Yes.
Just as I was a teacher or examiner, I am creating this issue to you. But in what way the immunization history will be helpful to me in this case? Is there any importance of the immunization history in this case, or this type of any respiratory cause, I will say, or simply directly if I ask the question, what is the importance of immunization status in a case of pneumonia? Forget regarding this case.
Okay, sir. If child is immunized, then it can decrease the severity of the disease, sir.
Which one? Which vaccine and what importance?
Vaccine preventing respiratory diseases. I think sir's question is this.
Yeah.
So for example, BCG if we given, it doesn't mean that we will not get tuberculosis infection, but severity of a tuberculosis infection will be lower.
Oh, okay.
Which kind of severe you want to say? What does BCG prevents? Like, which kind of CNS infection?
Disseminated tuberculosis will be less chances of disseminated tuberculosis. And
TBM, serious forms of tuberculosis. You can still get
yes.
Darshan, if I am presenting the case, I will not mention the BCG first. I will keep at the last.
Okay.
So reason is it is not, I will say, much playing the role in for the prevention of these pneumonias or infections, respiratory infections.
What is the protective efficacy of BCG? Are you aware?
That's why better to keep it, I will say, at the last. I will keep it, I will start very prominent in my chronology. First, measles.
Yes.
Because measles and related, even the pneumonia problems, complication is quite high. Second, I will say pertussis.
We are getting some answers.
Even third, I will say pneumococcal vaccine, heat vaccine. Because, all these, and last I will say, okay, tuberculosis also. I will take it this way when I'm answering. That measles, heat, pneumococcal, pertussis, and of course, even tuberculosis, like that. That means even examiner also understand they did not give the much weightage to BCG. Right? Okay.
Yes.
Please, these points are very important. Okay, go ahead.
Yes. Coming to development, development was appropriate according to age. Child is studying in 4th standard with good scholastic performance. Child is vegetarian diet with deficient in calories and protein.
Right.
There was no history of tuberculosis, diabetes mellitus, immunodeficiency, or any other long-standing disease in the family. And the child was not on any drugs at time of presentation.
Right.
So till now we have a 10-year-old developmentally normal female born out of non-consanguineous marriage, presenting with complaint of fever since last 1 month. associated with coughing and decreased oral intake with fast breathing since last 2 days with preserved higher function and preserved sensorium is mostly a case of any respiratory pathology, most common towards
Can you stop
parenchyma.
sharing here,
Yes,
Darshan,
sir. Yes,
for
sir.
a
Yes,
while?
sir.
For a while. I think again this is very important for all the postgraduates. That even at the end of the history, you are going to be asked to give the summary. Even in DNB exam and MD exams also. And summary should not be the repetition of the same story which has already been discussed. I think I'm sure in any exam, before coming to the summary, the points are discussed by the examiner. From this history, you try to make it. And in the exam, I will say write down few points on the paper so that when you are talking, even you can refer your note. But the note should not be read. And the summary should be in such a way that what is your inference from this discussion? What is your interpretation? That means prepare the hypothesis for the disease from the history. And for that, try to address what is the anatomy, what is the likely pathology, what is the possible etiology. That probably from the history we may not be able to make it, but common causes you can just consider. And what is the present status of the function of that organ. This is very important, that always make the summary in this way. Any system, first the anatomy, probable, you of course even in the, I would say examination or investigations, total anatomy and everything may be changed even. It does not mean that you are wrong. But according to this present, I will say discussion, your interpretation, this is my status. Even suppose somebody shows you the CT scan to you and it is totally wrong, then also you can say that from the history, this is my present status interpretation. And you are right, you are not wrong. So always try to find out and therefore here I think in this patient, is there any other student who would like to make the attempt? Please, I think these exercises should be done, not just to finish the discussion.
You want to add to Dr. Darshan has added, which will...
Yeah, you can, I will say, look, Dr. Priyanka, can you, Shalini, I think you were trying. You can put your, I will say, summary in your own way. You can say that this is my style. This was Darshan's style. That was his methodology. Shalini, but you can say that what is your, I will say, way of putting the summary in this case. And it should not be more than 8 to 10 sentences. Please.
Yes, sir. So based on
first I will
the
appreciate.
history.
First, I will appreciate you. That immediately you appear and started to speak. That's good. Please.
Thank you, sir. So based on the history taken, my summary is the system that is involved in this phase is most probably respiratory system based
Right.
on the symptoms, and it is most probably infectious cause because at 10 years of age it might not be congenital cause, and it is a chronic history chronic history of more than 1 month. So I will be focusing more on chronic infectious cause of respiratory
Very good.
system.
Always use the terminology, adjectives, acute, subacute, chronic. Then what is the progress? With the static disease, progressive disease. If it is progressive, it is rapidly progressive, slowly progressive.
Gradually.
What is the status of the, all these adjectives, many a times, it conveys your interpretation. You have not to make it clear. Automatically it is, I will say, already conveyed in your narration. So that type of story should come. Very good. Anybody else? But Shalini, would you like to make the comment that what disease you are suspecting?
So based on the history of chronic cough and fever and weight loss, I'm probably suspecting tuberculosis in this case.
Okay. Anything else? One is tuberculosis. Agreed. Some beyond that, because in the medicine, one condition we cannot consider. We have to pick
Child had
multiples.
a similar episode 3 months back. Was it not treated? Is it the complication
Yes,
of
ma'am. Recurrent pneumonia can also be one
And
of
my
the cause.
question will be changed. What is the definition of recurrent pneumonia? And then what is the definition of persistent pneumonia? And then what are you know, always the candidate is guiding the examiner. And therefore, before I will make the comment as a smart candidate, I will think that I will be able to answer if this question comes. Suppose if you think that I am not clear, better to remain away. Because, the number is, Shalini, even if I don't ask the question, I came to know that probably you are not clear regarding the definition of recurrent pneumonia. Or really, if you are clear, then Darshan has not given the much details. Right? If the only 3 months back, and that also he has not given the, I will say, details, recurrent pneumonia, what we mean by, how many times in some duration, any idea?
More than 2 times in 12 months duration, or
Very good.
more than 3 times in life with any one radiological clearance.
Very good. At least make this point clear. Good, I will appreciate. Even the examiner, suppose sometimes candidate is not able to make all the points. I come to know that, okay, he has read, he is aware, probably may not be able to make the point, all the points clear, but here he has made it. So I think here how it will be able to recurrent, that this is the recurrent pneumonia, right? Better to remain away. Anyway, any other condition? Any other condition? Beyond infection, suppose if you want to go to beyond infection.
Autoimmune in 10-year female.
Okay.
Then connective tissue or any.
Which autoimmune, Darshan, you would like to consider in this type of presentation?
There was also a history of typical rash, but SLE can cause this respiratory symptoms if there are a history of Monroe discoitis in a 10-year-old female.
SLE, always keep in mind, SLE first will present with the SLE, then we'll go with the complication. Direct presentation as the complication, difficult even if at all, sometimes it has come, as a clinician I will not consider. Because first disease will come, then the complication. Suppose somebody says pneumonic effusion without even pneumonia, then it is not pneumonic effusion, it is causes something else. Like that, right? So I think here even this, suppose weight loss 4 kg in 1 month, if you are right, what conditions you should consider? Even suppose if I focus only the weight loss 4 kg, can you enumerate some conditions in pediatric practice? Forget regarding rest of the history of this patient. But main significant is the weight loss 4 kg in 10 years old girl in a 1 month duration. Shalini, which conditions will come to your mind? One is suppose tuberculosis will be considered, I think in our country may not be wrong. Beyond that.
The cystic fibrosis?
Cystic fibrosis, 10 years it will present with the weight loss. Dr. Kronal is, yes, anorexia nervosa. Okay. Nowadays, probably this is the difference in the generation. Anorexia. Very important, always keep in mind with this 4 kg like or significant weight loss, what I mean to say. Tuberculosis, yes. Then can be the diabetes mellitus. Even the hyperthyroidism. Why not the malignancy? Right? So keep in, I will say this type of some condition, common condition. Suppose if somebody asks me, have you seen? Yes, I have seen, and that's why I'm talking. That many a time this type of weight loss, and I think anorexia nervosa, yes, nowadays it is coming up. That is the difference in generation. It will come last to my mind, but will come first to, I will say, this young generation, because it's very, I will say, coming up. Certainly it makes difference. Anyway, I think simply suppose somebody asking me to give the summary of this patient, simply I will try to make the attempt in this way. The 10 years old girl has presented with the chronic respiratory problem. From the symptoms and description, it becomes clear that probably the infective condition started with the airway symptoms, progressing, I will say, with this fast breathing, maybe due to the involvement of either the lung parenchyma or pleurisy or even the interstitium. On examination, it may become the more clear. And having this chronic condition, infective, common conditions point of view, I may consider tuberculosis first. But of course, even some other conditions like sarcoid, we cannot rule it out. Even it can present in this way. Some interstitial lung disease, yes, they can present. HIV cannot be ruled out. Even HIV also can present in this way. Or even some other malignancy also as a remote possibility in the pediatrics. But yes, with this really weight loss or something, we'll have to keep in mind. And I'm sure that if you put it, most of the examiners will accept it. This is just to give the illustration. Very nicely, but you have done the good job, Darshan, that we could
Yes.
get so many points for the discussion and we learned, all of us, not only yourself. Now I think you can go for examination.
Yes.
I think the examination madam will focus your points so that she can discuss.
Coming to vitals on admission, temperature was 102 degree Fahrenheit on right axilla for 1 minute. Heart rate was 102 per minute. Respiratory was 30 per minute. SpO2 saturation was 97% room air, and blood pressure was 110 by 70 mmHg. Coming to anthropometry, weight was
Always, I think better to go
Impression
for
of
interpretation of vitals.
interpretation of vitals. I would just like
okay. Okay. At the time of admission, child was hyperthermic with tachycardia and tachypnea while maintaining saturation on room air, but there was a fast breathing, as we can see in tachypnea, and blood pressure of the child was normal. So
I think 30, would you like to say the tachypnea for 10 years old girl? Or exactly you put the figure the same by definition cut off? More than 5. What I mean to say that not satisfying the much criteria of the tachypnea according to this.
Yes, mild tachypnea, yes.
Yeah. And even the heart rate. Another thing in 10 years old girl, please don't give the space. It should be pulse, not the heart rate. In 10 years old girl, it should be described as the pulse.
Yes.
Yeah.
and
Coming
there is
to
evident intercostal or some retraction seen at this point, you can tell us, like, because
on examination.
But if you're seeing 102, because 102 fever, 102 heart rate, and respiratory rate 30 is still acceptable. So with this, if you can see some, if you are seeing some retractions, you could have brought it here by mild or whatever.
Yes.
Were they there or not there?
No. There were no retraction. No retraction.
Retractions.
Okay.
No sound, no retraction.
No, sir.
Okay, fine.
Yes. Coming to anthropometry, child was weighing 17 kg, less than third percentile.
Why we are asking this? Because this is the complaint which brought the patient to your hospital. Parents identified and we are not getting. So it is a little like contradictory, but let's see how it goes.
Yes. Coming to anthropometry, child was weighing 70 kg, less than third percentile for her age. Height was 113 centimeter, less than third percentile, and BMI was 13.31, ranging between 5th to 10th percentile.
Now with this, 1 second, can you go back? Now with this, again our impression changes a lot. Like now I would say 17 kgs at 10 years, and even if she's lost 4 kgs, she was 20. So again,
20
right? So 20.
Yes.
So this gives a impression of a very chronic illness going on. I don't know that 3 months this your pneumonia or whatever it was there, and this is because this growth also doesn't look like a acute thing which has happened. Because if it is acute 4-5 kg weight loss, because 113 is a height age of around maybe 5 to 5.5 or 6 years, right? So this child is chronically undernourished, and really see that weight affected, I can understand. But why height was 113, you have to now think of, maybe it will turn out to be obese, but we have to think of many other conditions with this growth of this child. Maybe, but your calorie deficit was 400 calories, if I remember. 400 calories, 1700.
Yes, ma'am. 400 kilocalories. Yes, ma'am. 400 kilocalories.
Okay.
So, on coming to general examination was done under proper light and adequate exposure after taking.
Whenever you give this, you should always give your anthropometric impression. What is your anthropometric impression? This is third centile. But what is your anthropometric impression?
As child was having stunting and visible wasting, there was chronic under malnutrition. Child was coming from lower socioeconomic class, and there was chronic malnutrition, which may have lead to decreased immunity and increase chances of any infections to her. am I audible?
Yes, sir. Go ahead.
Yes, okay. Coming to general examination, general
The
examination.
only thing, Darshan, I'm not sure whether
Yes.
did you present this growth chart?
No, sir. Growth charts were
No,
not
sir.
very,
I didn't, sir. I didn't.
I think growth chart in any case,
very important.
Yes.
always, even I say to that extent that suppose by chance in the exam, if you did get the time, just show the growth chart to the examiner.
Yes.
But if you don't, I will show the growth chart. Your presentation may be the good, but still it will come down in the scoring. So
Yes.
never miss, I will say, the growth chart, whatever the case it is given to you. Please go ahead.
Yes. Yes.
And your head
There
to
was
toe
no.
examination, when do you come with the head to toe examination? That is also a heading, no? That have you done it or not done it? Once
No,
you
ma'am. I didn't. I haven't mentioned it. I
have to
went
do
for
a
general exam.
pediatrics, it's a like once you've done your interpretatory and your vitals, you have to do a head to toe examination. That also gives you a lot of clues.
Yes. Coming to general examination, there was no pallor, no icterus, no cyanosis, no clubbing, and no edema was there. However, bilateral cervical lymph nodes were palpable.
Size,
Again, you have to go into more details, not just palpable.
it's not multiple cervical, what was the size, were they discrete, were they matted, were they moving, were they not, were they tender, all those things. And your case, it becomes much more important, right? If you are presenting a case of enteric fever or meningitis or something, but here your clue, this is a big diagnostic clue, no? Lymph nodes. Can you tell us the thing? And other thing, when are cervical lymph nodes significant?
Even any other person, any other student can answer.
I have lost connection or Darshan has lost connection?
Yeah. Any person. More than 1 centimeter, Dr. Ranjan says, where but? Please, Dr. Ranjan, can you come forward? I hope you are there on the screen and not responding
Yes,
from viewers link. Yes,
good evening,
yes.
sir.
Good evening. Very nice. So 1 centimeter where? I think Madam was asked, lymphadenopathy is also very important in the examination.
In the neck region, sir.
Neck region,
Cervical.
okay. And what is the size for the importance for the inguinal?
I'm not sure, sir, for inguinal region.
Anyway, please, I will say for the sake of learning, please remember, and very important, as the madam said, even somebody here we are discussing online, but on the presence of patient, they will ask you for the demonstration that how will you palpate the lymph nodes of
all the groups.
various groups, right? And for that, we should know cervical, suppose as madam said, number 1, lymph nodes are palpable. What is the size? Where is the area? Whether tender or non-tender? Whether they are freely movable or matted? Any sinus or something is there, that also we should note. So all the details should be given. And cervical lymph nodes more than 1 centimeter, inguinal more than 1.5 centimeter, and axillary even any size, and even the epitrochlear, because these lymph nodes are very important, and from that become the important clue. Epitrochlear lymph node is palpable, maybe in the case of syphilis or Epstein-Barr virus. So that becomes the very important. So all the things should be given in details. Somehow I think that connection with Dr. Darshan is lost.
I think he's there. Dr. Darshan, are you there?
Because he's not seen.
Maybe his.
Dr. Lata, can you confirm?
Yes, ma'am. Yes, I'll just give me 2 seconds.
He's not there. He lost the connection.
I think that's why even his presentation also disappeared suddenly. He was talking, and so probably that must be the issue of this connection. Anyway, but meanwhile, I think we can discuss that. I'm not sure whether it is mentioned only cervical or what is the status of other lymph nodes.
I think he had written multiple cervical lymph nodes, 2-3 groups he had written, and dash centimeter. Either it was subcentimetric he had written, or I was not clear. That's
yeah.
about the size. So this is for all the postgraduates that if you're mentioning, it is very important to write the site and whatever sir has told. So, and whenever there's a respiratory case, your examination of cervical lymph node or axillary lymph node becomes very important.
Very important. Even in lymphadenopathy, always try to keep this type of the approach. As already we discussed that whether it is the localized or generalized.
Yes.
And what is the definition of generalized? That more than 2 areas non-contagious. If they are involved, it is generalized. Because, localized and generalized makes difference in our thought regarding the disease process. That's why we are going methodologically. And once it is generalized, you can find out that which groups are affected, which particular lymph nodes. And with that lymphadenopathy, you can link whether there is a hepatosplenomegaly or not. Because with hepatosplenomegaly lymph node, that means the RS system organ is involved. And then you can think for the RS system disease. That's a way of the thinking that how it helps. Later on, even you can go with this given case scenario, that what type the presentation of the patient, with the fever, without the fever. With fever, then again, probably we will think that RS system involved with the fever, common infections. Which infections? Even maybe I will say particularly the tuberculosis in our country, because RS system is commonly involved. Or even the HIV, yes, it can also present with this type of the RS system problem. Or even some other autoimmune disorders or malignancy. Even autoimmune disorders also, all of us know that the joint idiopathic arthritis as a cell can present, or even the malignancy, leukemia, lymphoma, yes, that we should keep. Even the Langerhans cell histiocytosis can also present with this lymphadenopathy. So that's the thing that how we can go with this approach in a case of lymphadenopathy. And then also acute, subacute, chronic duration. Then these other symptoms in the form of even the jaundice, without jaundice, it makes difference lot many. Even hepatomegaly, splenomegaly, mainly splenomegaly also makes difference. So I'm sure that all the features, if you put together, that will give you the idea that what is the probable explanation for even this lymphadenopathy or something. I think till Darshan comes back, we can have these points which we can now appear. Very good.
Sorry,
so
sir.
No issue. It is beyond our control. So it happens. So I think you can take the presentation and complete the presentation. Well, we'll come back for the discussion.
Yes.
But you have selected the good case for learning.
So coming to inspection of the coming to the respiratory system, first
I think anything on general examination, Darshan, lymph nodes. Can you make it clear only cervical or any other group is there involved?
No, sir, only cervical lymph nodes were there.
Only cervical.
Inguinal was not palpable, sir.
Okay, and was it significant in size?
No, sir, sub-centimeter.
So it is
sub-centimeter.
Very common to have reactive lymph nodes like this.
Yeah.
Yes.
Another thing, always Darshan, I said, don't invite the trouble in the exam.
Yes.
I think here, if there is not important to me, unnecessary, I should make the, I will say, presentation. Right. Okay, go ahead.
Yes. Coming to inspection, trachea was in midline. Apical impulse was present on left side. Chest wall shape was normal, but symmetrical. Chest wall movement is.
If someone is alive, apical impulse will be present, right? So you have to make a point where are you able to localize it. If you are not able to localize, you say it is diffuse or you could not localize it. Apical impulse will be there. If it is shifted, you have to tell shifted. If you have whatever you can make a visual impression, you have to give. Apical impulse present, it doesn't make to finish also.
Yes. Yes, and there were no retraction and no scar, and there was decreased chest wall movement on right side. Coming to palpation,
just Darshan, for the sake of exam, can you in the inspection go also the methodological. I'll say first you will look at the trachea.
Yes.
They will look at the chest even the shape according to the age of the patient. Then these movements. Then probably with the movements you will locate this apical impulse if it is seen. At least go in the details. whether if it is seen and you can appreciate even on inspection, you can say whether which space or somewhere inside, outside midclavicular line, shifted or something like that, you should make it. And then of course retraction and scar, sinus, something, okay. Suppose somebody has done even the pleural tapping or something or insertion of tube, that scar is seen, that also you should mention. Good. Then palpation.
Yes. Coming to palpation, on palpation, trachea was in midline, which was confirmed palpation. Apical impulse was fourth interscrotal space in midclavicular line. Chest wall movements were assessed for all areas. Apical expansion, they were bilaterally equal. Entry expansion in upper and lower chest were equal, and posterior chest expansion was also bilaterally equal. There were no tenderness or no chest crepitus on palpation of respiratory system. Coming to percussion, all area of the chest were percussed in a sequential manner. In coming to positing findings, right side memory, right side inframemory and infraxillary were dull on percussion. Inframemory, infraxillary, and infrascapular were dull in percussion. Otherwise, all area of the lung were resonant in on percussion, ma'am.
So what impression does this gives you? You have given specific areas. Does this give different impression of the lobes or the areas involved? Because you specifically mentioned
right side lower lobe was more looking infected. Involvement of the more one.
So what do you mean by lower lobe? Where is the lower lobe in the, like, if you think of quickly of the surface anatomy of lung? So how do you say lower? Which lobe looks involved here?
Right lower lobe was looks more involved in here. Middle and lower lobe.
Okay. So basically, we don't know it is fluid or it is consolidation. We don't know. But if you say lobe, so you should remember that if you are doing in the anterior, here most of this is the upper lobe, right? In the front,
yes,
it is upper. Axillary has all the lobes, and if you go in the back, mostly it is lower lobe. We don't know what the pathology is, but quickly you should know that this is how the lung lobes are divided.
I see anatomically and radiologically it is different. So we should know. I think on percussion, what we do is anatomically.
Anatomy.
I
So
think
that's what I'm telling you.
Yeah, I think you have put it appropriately. Supraclavicular, infraclavicular, right? Then I think memory and inframammary. Posteriorly, supraclavicular, suprascapular, scapular, intrascapular, infrascapular. Right. I think these are the and therefore anatomically when on percussion you are describing, better to restrict ourselves, I will say anatomical division point of view. Right?
Yes.
Because lobe and all the things will not come on the anatomical localization.
Yes.
Okay. So here according to you, inframammary, infraxillary, and infrascapular on the right side. Right. Even with that, you can even predict that which particular bronchopulmonary segment is likely involved. That is another way. That from your anatomical localization on examination, even you can predict that what does it indicate, which particular bronchopulmonary segment is likely involved. So anterior, if it is involved, anterior findings are more, that means it is indicating this particular superior bronchopulmonary segment also. Anyway, like that. Okay, Darshan.
Yes. Coming to auscultation part, on a sequential auscultation of bilateral lung fields, right side infraaxillary air entry was decreased when compared to other side, and right side middle and lower zone there were fine crepitations were observed. Coming to other systemic examination, coming to cardiovascular system, S1, S2 normal within limits. There was
look for because see now once you saw dullness, okay, resonance and all you have not tried, because once you have seen dullness, I don't know, it was dull, it was stony dull.
I think Darshan, anything you have to present on the examination? Anything is there?
Auscultation, did you, apart from the breath sounds, like rather than air entry, if you use the word equal breath, because you are hearing the sounds. You don't know how is the air entry, but you are hearing the sounds. So
Madam, I think Dr. Sonia, let him finish. I will say the finding. Then I will you can focus. Darshan, anything with other systems? Any positive findings did you get?
No, sir. It was a tubular type of breathing was there.
No, what I mean to say, respiratory system, okay. I think madam will focus after that. But CBS, CNS, or even the liver, spleen, anything did you get positive findings? Yeah, you can
There
finish
are
the
no positive
examination.
findings. No
Okay.
positive findings, sir.
Okay, what?
You finish your case, then we'll come.
CBS you mentioned normal. What next?
Yes. Coming to CNS, cell was active, however, it was irritable at the time of presentation, but oriented to time, place,
Anyway,
of
I think in one slide he has mentioned CBS normal, CNS, NAD, and non-tender, but liver spleen not palpable.
No, not palpable, sir, not palpable.
Okay.
No positive findings.
So I think these are the findings. Now you can stop sharing. Madam will focus for the examination.
Okay, sir. Yes.
Okay, so Darshan, one thing again you told respiratory rate, but apart from respiratory, again you have to mention if it is there, you have to mention their retractions. If it's not, there's no retraction. All those. But when you were coming to, once you have seen that once you have come to percussion, before that there's something called palpation. Was it done?
Yes, palpation was done, ma'am.
So did you mention, or I missed the vocal fremitus word here?
I think that TVF he has not mentioned total vocal.
TVF I missed, ma'am.
It's very important. Why? Because you have to make clinically a diagnosis. See, you have done a percussion and you are saying there's a decreased breath sounds. We know that. We are saying when you are coming sequentially, when you say that the percussion is done, so before that palpation has to be seen, right? So vocal fremitus will give you a fair idea that is there fluid, is there consolidation, something that as sir has told, we may miss. It might be right, it might be wrong, but that should not be missed, right? One, that is important parameters you should have seen. And she's a 10-year-old. Like sometimes if it is a 1 year, 2 year, even we don't ask. This is a cooperative child where she's not having much distress. Her saturations are maintained. You could have very well done a fremitus, and I hope you know how to do a fremitus. Right? Okay, here we can, right? Then again, when you have come to the auscultation part, auscultation, what did you tell? Breath sounds were decreased on one side. That is what I heard. Apart from that, so because see, we have come to auscultation, we still don't know what is the pathology. Here, if you could have done just a resonance, it would have given you a fair idea if the resonance.
Yes.
What are the conditions where fremitus is increased or decreased? How what idea will the how will your fremitus and resonance help you in making a diagnosis clinically?
There is consolidation. Yes, consolidation. There is solidification of the tissue. Then there is a better conduction. So TVF is increased. But if there is a pleural effusion or there is fluid collection, then will be decreased TVF. So it can give the idea of the consolidation of fluid collection like that.
Okay. So, but here you are also finding something. You told bronchial breathing also on the same side. Did you tell me that, or something?
Right side, middle.
Right side.
Right side, middle. Right side, I got fine grafts.
Right side there.
Slide.
Again, you have used the word lobes. I told don't use the word lobe. You have to use the ears only.
Memory, yes.
From every memory, you got your bronchial breath. Grafts were there, and bronchial breath sounds were there. Okay. So we mean to say you don't miss anything. Like you have to go stepwise. Whatever maybe your diagnosis, nowadays you are doing USG, you are doing CT chest, you are doing everything, but your clinical points should not be missed, right? Anything else?
Yes.
I think Darshan, let me go to others. Ranjan, I think you are vocal. You are responding very nicely.
Yes, yes.
On inspection, somebody say that position of the trachea, how will you decide from inspection?
Sir, we will ask the child to look forward without any tension or any relaxed position. Child should be in relaxed position. So there will no infection. Then we will put the 2 finger on the.
No, I'm asking for the inspection, Ranjan. We'll go for the palpation after that. But the first on inspection, can you make the comment on the position of the trachea? And if at all, yes, then how?
If trachea is deviated, then absolute cell will be undue prominence of the sternocleidomastoid mustard head.
Very good. What do you call it? That sign?
What is that sign?
Trail sign, sir.
Yes.
Trail sign, sir.
Or even the sternocleidomastoid sign. Suppose if you don't remember the name, it is also the name. Very good. So I just simply looking at that which, suppose some muscle is very prominent on that side, that means it indicates the trachea is on the, suppose the right side muscle is prominent, that means trachea is shifted on the right side. That is on inspection. Now, Ranjan, on palpation, which you were describing. On palpation, how will you look for the position of the trachea?
Sir, we will keep two fingers on the medial end of the clavicle. Then we will try to insinuate the middle finger in between the medial end of the clavicle, sir.
Clavicles or muscles? Clavicle head of the sternocleidomastoid muscle, right?
Yes, sir. Yes, sir.
That's what I'm telling you. Even you speak so precisely that examiner should feel that I have forgotten, but this candidate reminded me. Then I'm sure you will get the marks. But your, I will say, methodology is right. So you will use the two fingers. Then what you will do?
With the middle finger, sir, we will try to see for any deviation.
Again, that means you are using the three fingers. One is, I will say, index and ring finger. And that you will keep, I will keep at the heads of the clavicle heads of the sternocleidomastoid muscle, or inner heads, medial heads, you can say. From the middle finger, you will try to trace this trachea, right?
Yes, sir.
And see on which side your finger goes. And from that you can decide. Any other side?
Yes.
This is one side, one of the methods for trachea on palpation. Any other method? Very simple.
Deglutition, sir, we can try patient.
Even simply you can, with your finger, you can try to trace this trachea. Suppose trachea is shifted, then automatically your finger will be in the space, which is empty space. Otherwise, centrally you can locate the trachea. So that is very simple, or by this method. So all these questions people are going to ask you. Another thing I will say in the exam point of view, Darshan, examination, suppose if somebody is focusing, in the exam they will do like this. Then inspection, palpation, percussion, auscultation. Put the positive findings. Positive findings will create some exact impression. Does it indicate really the consolidation, collapse, pleural effusion, pneumothorax, or something else? Sometimes there may not be distinct even the clinical findings in the case of the combination. Suppose collapse consolidation, then may not be the, I will say, very clear-cut findings. But at least I will suggest you, never manipulate the finding. Findings will be, at least you should be able to show to the person. From that finding, you can try to derive this possible pathology. Suppose I will say, that's why, as an illustration will take it, Ranjan, suppose the case of pneumonia. Can you describe inspection, palpation, percussion, auscultation findings? Suppose a similar 10 years old, that means a very cooperative patient, where you can examine very appropriately, patient is allowing, and therefore all the points, as Madam said, a very young child, serious child, SpO2 is not maintained, hypoxic, we will not do. Anyone may not allow, and we should not try. But suppose in such a stable patient, and in exam most of the time they will keep such stable patients. And such patients are there. In a case of pneumonia, what will be your findings? Can you enumerate inspection, palpation, percussion, auscultation? That will be a good exercise for you for the exam.
In pneumonia, sir, in inspection, as you told, the child is stable, so it's less likely that we will see any sign of respiratory distress there, like subcostal.
So maybe mild can be there. In a stable patient also mild.
Even severe pneumonia also, if you go to the WHO classification.
Yeah, exactly the madam said. If you go for this classification, no pneumonia, severe pneumonia.
Severe pneumonia, even pneumonia also has retraction.
Yeah, in pneumonia also tachypnea and some restriction can be there.
Yeah, so don't.
And that type of patient can be kept in the exam, right? So, but very important point which I want to trace over here. You know, tachypnea or fast breathing is very important, I will say, sign for diagnosis of pneumonia. Please, you know, the medicine, certain signs they have qualified, which are scientifically they have, I will say, studied, titrated. And they found that these some specific signs are more reliable. There are several, I can give several examples, but this fast breathing or tachypnea is WHO has defined by the scientists that is a very important, sensitive, reliable marker for the diagnosis of pneumonia, even by the paramedical people. Because we wanted to devise this to prevent this mortality rate, to decrease the mortality rate of under 5, where the pneumonia is the major killer. And for that is, so always start, I will say, for the pneumonia first from the fast breathing, tachypnea, indrawing, any sound, like that. Then on the inspection itself, you can say, trachea, even the location itself, then the chest, even the shape of the chest, then even the movement of the chest, then even the apex beat. I think this will be the sufficient on inspection. Similarly, on palpation Ranjan, what you will get on palpation in a case of pneumonia? Suppose liver pneumonia significant with all the signs it is there.
Sir, we can have a reduced chest expansion if there is a lobar pneumonia on the affected side.
Maybe that means that is a diminished movement may be there. Good. Then.
Yes. And similarly, sir, we can if we go for the fremitus, then we will have the fremitus can be decreased on that side, sir.
Tactile vocal
also there
fremitus
can
be increased,
So
right?
it won't decrease beta. Decrease will be fluid will decrease, right?
In pneumonia, it will be increased. Very easy transmission. The principle of hearing, if you know, more solidification, there is good transmission. So here it will be increased, right?
Increased.
And what else on the palpation?
Sir, since it's a if lobar involvement is there, then we can also see for the tracheal shift can also be there, sir. In that.
Why in a case of pneumonia? Unless there is some complication.
Sir, effusion, in case of effusion, we can see the tracheal shift is there.
Why I should invite the trouble unnecessarily? Because the examiner asked me only the pneumonia. So I will say what you said is inspection. The trachea is usually central. There may be the diminished movement of the chest on that side. Tactile vocal fremitus is increased. I think this will be on the findings on palpation. Then I will go to percussion. Percussion is usually the dull note. Auscultation, if you see that, what type of breathing you will get? Bronchial breathing.
Bronchial breathing.
Vocal resonance increase. According to the stage of the pneumonia, even you may get some crepitations, usually fine crepitations.
But you understand by bronchial breathing, Ranjan, how will you identify this bronchial breathing?
Vesicular breathing, somebody will ask what is the types, then vesicular breathing and bronchial breathing. How will you differentiate?
Though after listening only, but clinically or someone asks you what is bronchial breathing, breathing, what will be your answer?
You should have the idea. Darshan, any idea?
Higher pitch and louder intensity, and there will be pause between inspiration and expiration. But in vesicular breathing, there is no pause, and there is a 3 gm to 1 gm ratio of inspiration to expiration, and it is a quieter and lower pitch, lower intensity. Vesicular is.
Anyway, it is good attempt. Right. Anyway, I think we have already.
It's already 11.
We have taken more time, but certainly it was. I think Darshan, you have any investigate something to reach the diagnosis? I think we can learn if you
finish the case.
You have any presentation now?
Yes, sir. Yes, sir. Plural foot diagnostic. Plural foot tapping was done.
I think whatever you have, you can just present it. Then we'll go for the end. Whatever the investigations you have performed, just you can show to all of us.
On investigation, CRP was markedly elevated, otherwise always within normal limits. Coming to urine examination, there was a finding of urine pulse 23 urine pulse were there per high power field. Serum LDH was marked.
Does it indicate UTI?
No, sir. It was incidental findings.
Not incidental. What is the explanation? What is the explanation? Suppose if you go for urine culture, I think urine culture may be sterile.
Yes, sir.
And this
Right,
few percent,
Symptomatic bacteria.
even any febrile status, not necessarily UTI.
right by you.
Probably
Yes.
23 is a little bit high, but usually few cells can be there any febrile status, and therefore don't give the undue importance to that. Right.
Yes,
So here
yes.
probably it may be the part of the it's a part of the inflammation. It can be.
Yes.
I will explain in this way and be palatable. People will accept it.
Yes.
Okay.
And
Next.
serum LDH was markedly elevated. For radiologic investigation, we went for chest X-ray. It is a chest X-ray PA view on with adequate exposure, and on right side we can see obliteration of the costophrenic angle with menisci level suggesting of right side pleural effusion.
Okay.
And, further, we went for sonography, which suggested the moderate pleural effusion with 180 to 200 volume with thin internal septation. And then, so we went for a diagnostic tapping and pleural fluid examination was done, which was higher in protein. Protein was 5.9, glucose was 60. There were 1,250 to 1,200 were WBC, lymphocyte predominant. Pleural fluid LDH and ADA was also markedly elevated, while gram culture and Zadenstein and TrueNAT came to be negative. And on keeping the fluid still, we had a cobweb formation, and then it fulfilled the lights criteria for exudative transfusion, as the ratio were more than the pleural fluid and protein ratio was more than 0.5, LDH ratio was more than 0.7, and pleural LDH was more than two-thirds of the normal level of serum LDH, so suggesting toward exudative effusion. So after proper clinical history, we have right side decrease dull in percussion with decrease air entry, fine crabs, excess showed right side costophrenic angle obliteration, and we confirmed this by USG, which was a right side moderate pleural effusion, and USG kind of tapping was done, and cobweb formation in predominant lymphocytes with higher level of AD and LDH suggested Cox etiology. We started a patient on the AKT.
Whether the gene expert was done?
Yeah, he has written
TrueNAT was sent.
It was negative.
Yes, it came to me.
Okay.
And ultimately, sir, after third day of admission, child had shortness of breath, increased.
Darshan, what you've written is after ruling out any form of immunocompetent state. What do you mean by this?
Before starting AKT, we confirmed that child was not having any immunodeficiency.
The word you have framed it wrong. That's how I have
Yes, there is type of typing error is there.
But how did you do it?
How do you and why did you think of even if you have thought of, because workup of immunodeficiency is a huge task. So why one thing, if you're HIV is negative as it is mentioned in your NTEP protocol, right? When you go through the algorithm, any child. So that if you would have said secondary immunodeficiency HIV you have done, it justifies. But in a child of 1 month where you're getting a effusion, there's no recurrent pneumonia, there's no growth failure. I'm still concerned about her 17 kg weight and 113 height. But did you really did and this either you should have written any form of immunocompromised state, and immunocompromise also have you done so early? I am a little doubtful. You can proceed.
No. I only went for HIV testing. That's when I should not have mentioned.
But this आपने statement भी गलत दे दिया ना बेटा, immunocompetent डाल दिया.
Darshan, I will show you that why we can build the bold statement regarding the immunological status. You have anything to present now?
No, sir. We started patient on AKT and child was discharged. On the third of admission, we had to go for again the tapping because as child was having breathing difficulty.
Very good.
Ultimately, child was completed on AKT and discharged.
Okay. Can you stop sharing? I think few very important remarks for our learning.
Yes.
Did you go for any other investigations to prove the tuberculosis?
No, sir.
No,
I think
it's all right. But what we should do, nowadays, number one, National Tuberculosis Elimination Program. I think last revision was done in 2022. And according to that, we should follow. This is fairly good to convince, I will say, presumptive tuberculosis, probable and confirmed. Now, from this point of view, we are falling in the category of probable tuberculosis, not confirmed. Because for confirmed, all of us know that we should have the bacteriological, macrobiological diagnosis. For microbiological, either I will say for sputum, AFB, or culture or molecular diagnosis, gene expert, ultra, or anything we'll have to do.
Child had a productive cough beta, so induced.
Yeah, I think in that patient, that's why I will say that you must have gone for the suppose available the sputum, if not available even the induced sputum. Or even in such a patient, on the contrary, I will go for even the CT scan. If possible, the lymph nodes are seen. Better to go for this lymph node biopsy and for confirmation. It's at the most, not even you can go for the BAL, which is very important.
At least the induced sputum could have tried.
Yeah, induced sputum you must have tried. And the reason is, nowadays, for our learning, you will say that nowadays these things are very important. Fairly good from the appearance of the fluid, somebody considers tuberculosis, probably convincing. But at the same time, and therefore on the contrary, if you go for the previous X-ray of 3 months back, it must be, I will say, showing some evidence of tuberculosis. And the second thing regarding the immunity, in this patient, I can make the bold statement. In the medicine, I usually don't make the bold statement. I'm telling you.
And other important thing is we should also remember that pleural effusion is not an infection. It's a hypersensitive state, right? So you might not get a bacteria over there because it's because of hypersensitivity, the subpleural will.
Yeah.
So you might not get there, but the induced sputum would have given gastric lavage for AFB would have. So anytime you see all efforts you should make all efforts. You do not get, then clinically you can go, but please don't. Small things which can be done in your wards, right? BAL may not be possible in all the setups, but these two things are always possible, right?
As far as I remember, sputum AFB was sent.
Probably they have not mentioned.
It was sent, ma'am. We had not mentioned that it was sent.
Immunity point of view, one point which I would like to highlight. From the various presentations of the tuberculosis, you can predict, may not be always right, but most of the times we are right. Whenever the tuberculous pleural effusion is that, it indicates the good immunity of the child.
That's what I was trying to tell them. You'll not get the bacteria.
With the bad immunity, this tuberculous pleural effusion is indicating the good immunity of the. This is one of the presentations of the tuberculosis, the good immunity. Suppose bad immunity, even the 10 years old girl, usually they go with a destruction, fibrocavitary lesions, because they cannot stay. Here, I will say ultimately we know that tuberculosis pleural effusion is the tuberculin hypersensitivity. And tuberculin hypersensitivity will come with the person with a good immunity. I think here, of course, the weight, and for weight loss, and it's a different thing. If you know, there are the various, I will say, these cytokines, which are responsible for this decreased weight, any disease, malignancy, tuberculosis, HIV, autoimmune. These are basically cytokines. Interleukin-1, interleukin-6, even tumor necrosis factor, gamma, interferon gamma, and every cytokine is having the very characteristic for decreased appetite, for fever, for even weight loss, for even the other symptoms, even some skin lesions. So these cytokines are playing the role. It's a different issue. But immunity and this compromised immunity is something different. And of course, HIV and everything you've done. I think here I will end with this one thing. Diagnosis of tuberculosis is very important with, I will say, microbiological confirmation. Nowadays, that is very important. Second thing, we'll have to inform to the, I will say, government authority. That is very important that we'll have to go for the information. Third, even further, follow-up should be known. Follow-up at every place, I will say exam point of view and practice point of view I'm talking. First follow-up after 15 days, later on every month, till you complete the duration, and then every 6 months till 2 years. Here the questions will be there, what you want to see with every visit, and it is clarified, it is classified, that every pediatrician or I will say any medical person of this country should know, and we should follow up the patient. Regarding the steroids and other things, regarding the AKT doses, everything is very important, and I'm sure that it is going to be discussed. Just from the, I will say, our exam preparation point of view, I'm talking, and these things are going to be the very common in any this type of the tuberculosis. Anyway, already we have crossed 11, so it's a very high time for us to end over here. Dr. Lata has also now made the video on that, please. You can.
No, sir, no, sir. No, sir, no,
So,
sir.
but I will appreciate, Darshan, that your selection of case certainly good for the learning, for the discussion. I hope that many points we could derive with the help of Dr. Sonia, and all of us have learned. And please, students, as far as possible, always go for the examination of the patient very appropriately. Make the multiple, I would say, practices so that you can do better in the exam. So, with that, even I should appreciate your mentor, your institution as a whole. I hope that I'm sure that Lata is also working at the same institution. That even
Yes, sir. Sir, I pushed him. Sir, I pushed the second year student.
I
told
know
him you go
always.
and present. It's
Always it requires somebody to even to guide, to push, to prepare them, and even I will say any student, when at least he's presenting, I will say making his video on and talking is always appreciable. Not that easy. I understand. And even still with that also, your confidence was good, your tone was good. That always, it makes difference in your tone. Of course, I will not be overconfident, but certainly we should be the confident. That also makes the difference. And even some of the students were also responding very nicely. We had, I was lots of the inputs from Dr. Sonia, which I'm sure that is going to be quite useful to all of us. Over to you, Dr. Lata, with a word of gratitude and thanks to you for giving us this opportunity. Over to you, Dr. Lata.
Thanks to you, sir. Thanks, sir. It was a really very nice session. Thanks to Sonia ma'am. I think Jhankhana ma'am is with us. Jhankhana ma'am, are you with us?
Yes.
Yes, Dr. Jhankhana is there.
Yes.
Ma'am, for forward of thanks.
Yes. Thank you, Prajapati Shah. Thank you, Dr. Sonia. And lot of thanks to Dr. Darshan.
Okay. It's my pleasure, ma'am.
And from this case, with the help of the Dr. Sonia and Dr. Baldev Prajapati sir, we also, general practitioner, learn from the history and examination, we can identify the system. In system, particular organ, we can say what is the pathology, what is the pathogenesis of a disease. Now, this is the beauty of this case presentation. Thank you, sir and Sonia madam. Thank you, Baldev Prajapati.
Ma'am, thank you for the opportunity. With sir, it's always a learning opportunity for us. I always come back whenever I get a message like that.
Sure.
Thank you, Sonia. It was really great pleasure.
Thank you all of you, and good night.
Good night, everyone.
Good night.
Good night.
Good night.